to Southern Union EMS's Toxicology lecture series. This is part 7. We're going to discuss psychiatric medications, over-the-counter pain medications, and metals and metalloids. To begin with, we're going to talk about several classes of psychiatric medications. They are designed to alter dysfunctions of mood and affect thought, orientation, and perception. Antidepressants accounted for over 75,000 adult exposures and were the fourth most common pharmaceutical involved exposure in 2014. Ingestions may have been intentional, and polypharmacy may have been present as well. The first group we're going to talk about are tricyclic antidepressants. Tricyclic antidepressants are particularly dangerous because they're very cardiotoxic when a patient overdoses on these. These often do work well for depression, but they are often prescribed as a last resort once the patient's been refractory to other types of antidepressant medications. Sometimes these are going to be prescribed for insomnia, eating, and personality disorders. Your common TCAs, amitriptyline, nortriptyline, and clomipramine. The classification used for endogenous depression, reactive depression, and depression related to alcohol and cocaine withdrawal. TCAs are absorbed by the body within the first couple of hours after ingestion, and they easily cross the blood-brain barrier. They work as norepinephrine and serotonin reuptake inhibitors, and overdose can cause sympathomimetic and serotonergic as well. Toxic ingestion, tachycardia, tachypnea, hypotension, hypothermia, also ECG changes as well. Also works against the parasympathetic nervous system, has antimuscarinic qualities, which produce signs and symptoms similar to anticholinergic toxidrome. Remember the saying, hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. In other words, a patient will exhibit hyperthermia, dilated pupils, dry skin, mucous membranes, reddened skin, and agitation or delirium. Be alert for ECG changes with TCA overdose, such as prolonged PR interval, tachypnea, widening QRS, terminal R wave greater than 3 meters in AVR, and prolonged QT interval. Altered mental status, delirium, and seizures are also possible with toxic ingestion. A patient who presents with serious signs and symptoms within 6 hours of ingestion should be considered critical. With these patients, you do have an antidote or a drug to give, and that's going to be sodium bicarbonate. So sodium bicarbonate should be given in the case of tricyclic antidepressant overdose. If the patient happens to have seizures, then you would want to consider benzos and intubation. This patient is at great risk and they need to be transported to the hospital ASAP. Includes monoamine oxidase inhibitors or MAOIs. You ever watch TV and you see a prescription commercial come on from a big drug company, and at the end, when they speak really, really fast, they say, please make sure you do not take this drug. If you are on MAOIs or have taken MAOIs in the past 2 weeks, please contact your doctor. Please let your doctor know if you're on MAOIs. And that's because these drugs are used primarily to treat atypical depression, but they do not play well with others. Monoamine oxidase is an enzyme that removes neurotransmitters from the brain, and these drugs prevent regular removal of the neurotransmitters, and in toxic levels, MAOIs can block these enzymes for a short or long duration based on the medication. Symptoms are often delayed 6 to 12 hours or more after ingestion, have cardiovascular effects, including hypertension, tachycardia, palpitations, chest pain, diaphoresis, and atrial dysrhythmias. Common MAOIs include Nardil, Marplan, and Parnate. Also, other effects include marked hyperthermia, muscle rigidity, respiratory failure, delirium, seizures. Prepare to manage this as if it is a life-threatening event. There is no antidote available for MAOI overdose. Administer high-flow oxygen. You may have to consider rapid sequence intubation. The use of a non-depolarizing paralytic such as rocuronium is recommended. So in the case of a MAOI inhibitor overdose and your RSI in the patient, you do not want to use succinylcholine. If seizures occur, treat with benzos. And if the patient is hyperthermic, you may want to consider midazolam. SSRIs, selective serotonin reuptake inhibitors. These include drugs like Prozac, Paxil, Celexa, sertraline, Lexapro. They have fewer anticholinergic and cardiac effects than TCAs, and they have a much larger therapeutic window than MAOIs. They're a relatively safe drug. They enhance the serotonergic neurotransmission and inhibit the breakdown of serotonin. They have few cardiac effects as well. Assessment, almost half of the patients may be asymptomatic. Shouldn't be taken with alcohol. If it is, look for tachycardia, hypotension, lethargy, and then other common symptoms: nausea, vomiting, dysrhythmia, sedation, and tremors. Management's mainly supportive for these patients. If widening of the QRS occurs, consult with med control a consideration for sodium bicarb if you have a patient that's overdosed on SSRIs. Now, there is a condition with SSRIs called serotonin syndrome, which can occur with drugs that increase central serotonin neurotransmission. So all of the previous antidepressants and then some of the other medications all can cause that. Serotonin syndrome is a idiosyncratic complication. Occasionally occurs with these antidysrhythmic therapy. Presentation can vary widely in severity and may be complicated by consideration of single or multiple substance toxicity versus serotonin syndrome. Pre-hospital treatment is supportive, and you may consider cooling if hyperthermia has been induced. Lithium, commonly used mood stabilizer, and it's the main treatment for bipolar disorder. Assists with dampening mood swings rather than affecting the normal mood. Almost completely absorb the GI tract. It's got a very narrow therapeutic window with a high risk of toxic levels and overdose. Early signs and symptoms: nausea, vomiting, hand tremors, excessive thirst. With increased toxicity comes increased neurologic symptoms: ataxia, muscle weakness, and incoordination, abnormal thermoregulation, blurred vision, and hyperreflexia. Eventually, the patient may have seizures and become comatose. For lithium overdose, in the field, mainly supportive. Fluid bolus may be required if they're hypotensive. Your non-prescription pain medications often are overdosed because the general population believes these medications to be relatively safe, but there can be some dire consequences for overdosing on several of your non-prescription pain medications. You've got your non-steroidal anti-inflammatory drugs, or your NSAIDs. They're rapidly absorbed from the GI tract before being eliminated. Most of your problems with NSAIDs occur due to long-term use, where they erode the gastric lining and they cause ulcers and bleeding. Many of your NSAID overdoses are asymptomatic. At toxic levels, the signs and symptoms may include nausea, vomiting, and abdominal pain. So your NSAIDs primarily affect at the gastric area. Management in this case, if they have seizures, treat with benzos, treat hypotension with normal saline. A unique side effect to this NSAID overdose is aseptic meningitis. The patients present with complaints of stiff neck, headache, and fever. Discontinuing use generally resolves the problem, and patients should be evaluated at the hospital to rule out other problems. Salicylates. These include aspirin, bismuth, subsalate, liniments, and hot air vaporizers. Toxic levels from excessive dosing of salicylates for analgesia or fever control. The ingestion of 150 milligrams per kilogram would be mildly toxic. 150 to 300 milligrams per kilogram would be moderately toxic. Moderate toxicity includes vomiting, diaphoresis, hyperipnea, ringing in the ears or tinnitus, pulmonary edema, and acid-base disturbances. And then 300 milligrams per kilogram and greater ingestion is severe toxicity, may produce metabolic acidosis, may note tachypnea and hyperipnea. This is the body's compensatory mechanism trying to correct metabolic acidosis. Overdose in adults is usually intentional and could be a fatal event, especially if the patient presents with high fever, seizures, and cardiac dysrhythmias. Assessment for these patients, mainly supportive, high concentration of oxygen, boluses of normal saline for hypotension, administer 1 dose of activated charcoal if instructed by medical control, and you may consider a consultation with medical control regarding urine alkalization with sodium bicarbonate. So acetaminophen or Tylenol is usually well tolerated with few side effects. However, the belief it is harmless leads to toxic exposures. There's also a lack of awareness that it is an ingredient in many other preparations, which may lead to an unintentional overdose. It is absorbed rapidly through the GI tract, but it has a huge effect on the liver and the kidneys. There are 4 stages of acetaminophen toxicity. Stage 1 being less than 24 hours. Stage 2 being 24 to 72 hours. Stage 3, 72 to 96 hours, you start seeing metabolic acidosis, renal failure, coagulopathies, and recurring GI symptoms. And then stage 4 is 4 to 14 days, and this is where you start seeing either a slow recovery or the liver will shut down and the patient will die. The antidote for acetaminophen is acetylestine. And ideally, it should be given less than 8 hours after ingestion. It's going to be given in the field. It's not going to be given in the field. It's going to be administered in the hospital because it's based on the lab test and the acetaminophen levels within the serum blood. So there's no way for us to detect that in the field. Metals, lead. Most of your toxic ingestions are the result of environmental contaminations for lead poisoning. Absorption usually occurs via the respiratory or GI tract, and excretion from the body is slow. Once in the body, approximately 90% of the lead is stored in the bone. Inorganic lead can also cross a placental barrier and negatively affect fetal development. In pediatric patients, elevated blood lead levels can cause adverse neurologic development that may significantly impair cognitive function. Its excretion from the body is incredibly slow, with a half-life of lead in bone estimated at 30 years. Most organic lead exposures occur in the occupational setting, although they can also occur from gas sniffing, where lead to gasoline is available. Once in the body, tetraethyl lead is metabolized to inorganic lead, with triethyl lead being the primary cause of CNS toxicity. Lead is associated with a long list of signs and symptoms, as you can see here: CNS, GI, renal, also hematologic. Management for this patient is going to be pretty much supportive. You want to be careful with fluid administration. Cautious fluid administration is required to avoid worsening of any cerebral edema. Iron. Most of the iron that you receive is through your diet, and there's really no reason, unless somebody's iron deficient, to take any type of multivitamin that contains iron. Toxic effects reflect the amount ingested. Mild to moderate toxicity is going to be 20 to 60 milligrams per kilogram, where severe and potentially lethal toxicity is going to be 60 milligrams per kilogram and greater. In the average 70 kilogram adult, the body's iron supply consists of about 4 grams. Roughly 65% of it is found in hemoglobin. Excessive amounts of iron in the body can speed up the formation of oxygen-free radicals, which creates metabolic acidosis. It may also have an effect on the coagulation cascade in the liver, causing significant coagulopathy. And the toxic effects of exposure reflect the amount of elemental iron ingested, with mild to moderate toxicity, as I mentioned earlier, 20 to 60 and 60 milligrams per kilogram for severe and potentially lethal. From the time of ingestion, iron poisoning will usually cause symptoms within the first 6 hours: vomiting, diarrhea, abdominal pain, hematemesis, tachycardia, hypotension. Patients are commonly in metabolic acidosis and become tachypnic as the body attempts to correct the pH. Later stages will include liver failure, profound shock. Pay attention to ABCs, provide supportive care. Activated charcoal will not work in iron overdose. Mercury. Mercury is very toxic. There's toxic effects from all forms of mercury. Lipid soluble and quickly accumulates in the liver, CNS, and the kidneys. Your assessment is going to depend on the type and the route. Management is going to be supportive. Arsenic, very, very dangerous, involved in approximately 8% of all heavy metal poisonings. Used in many industries, so often is a source of unintentional exposures. Assessment, the clinical presentation is going to depend on the type, the amount, the concentration, and the rate of absorption of elimination. There's a whole basket full of assessment findings with arsenic. Your management is going to primarily be supportive. If they're in torsades, we will consider magnesium sulfate. So this ends part 7 of the toxicology lecture. If you need anything from me, my email is nickray@suscc.edu. Thank you.